served, but in the gallery. And it's going to be followed by a half-hour networking session. And this is with Dr. Asta Bansal. So hope you'll all join us for that. Thank you.
Great.
Over to you. Thanks.
Thanks. So good afternoon, everyone, and welcome to the second week of CHES rounds for the academic year. For those of you who don't know me, my name is Samantha Anthony. I'm a senior scientist within CHES and a health clinician scientist in social work. And I have the pleasure today of moderating today's session and introducing our speaker. So it is my pleasure to introduce Jia Lin, who is a master in public health and is a clinical research project coordinator working with our team here at CHES. And in her role, Jia leads multiple clinical research studies across the research pipeline, including the study today that she's going to be speaking about, which is a multi-phase cross-Canada study exploring the experiences of Indigenous children and families who have received a solid organ transplantation. Rooted in patient and community engagement, this study employs storytelling to consider the multiplicity of knowledge, including Indigenous knowledge, to advance child health equity. Jia's research interests include youth engagement, digital health, health equity, and applying critical qualitative approaches to amplifying patients' voices. So without further ado, all over to you. Thank you very much.
Thank you. And people can hear me? Okay, so hi everyone. Thank you for having me. I'm super excited to be sharing our program of research. Exploring pediatric solid organ transplantation for Indigenous children and families. And I'm really welcoming you on the journey of researching with Indigenous patients and transplantation. I'd first like to acknowledge our funders and supporters for which this research could not be possible. So,
Right, I'm so sorry, I can't hear you back here.
Oh.
Try to talk a little bit for race.
let's try it.
That's better.
That's better, right?
Yeah.
You might have to hold it up. How's that?
Yeah.
Better? Okay, I think I'll just have to speak a little louder. So thanking our funders and supporters, Canadian Blood Services, CHR, and the Edward Leong Center for Healthy Children. So I'll start with the land acknowledgement. And as a settler, I do want to acknowledge the land that Healthy for Sick Children resides on, which is the traditional territory of many nations, including the Mississaugas of the Credit, Anishinaabe, Chippewa, the Haudenosaunee, and the Wendat peoples. It is now home to many diverse First Nations, Métis, and Inuit peoples. I say this land acknowledgement respectfully to honor the rich Indigenous governances that have existed, that are ongoing, and that will continue existing into the future. For me and our research team, this acknowledgement reminds us that we are accountable to our relationship with diverse nations, the lands, the waters, the animals, the elements, and us as settlers continue to benefit from this land that we live, learn, work, and play on. And I keep this acknowledgement close to me. So these are the objectives of today's talk: develop a deep understanding of the ethical and relational responsibilities of doing health research with Indigenous populations, explore the role of patient and community partners in co-designing culturally relevant research in pediatric solid organ transplantation, and present preliminary findings from the research program, exploring the experiences of solid organ transplantation for Indigenous children and families. So I know Dr. Anthony introduced me, but I wanted to also introduce myself. My name is Jai. I'm a clinical research project coordinator, and I've been working with Dr. Anthony for about 5 years now here at CHES. I also want to introduce our lab, the Anthony Lab. So our collective research goal within our lab across our project aims to examine the biopsychosocial impact of pediatric transplantation on patients and families, and to improve outcomes by transforming clinical practice. And so what really draws me to this work is the emphasis on health as a holistic manner. So not just the absence of illness, but also the psychosocial, emotional, and spiritual elements of well-being. So I wanted to highlight these 3 pillars here of Dr. Anthony's research program. So engaging patients meaningfully, focusing on patient-identified priorities, and integrating their experiential knowledge through patient-centered partnerships. Capturing the patient's voice, exploring the transplant experience from the perspective of those who live it and create meaning from it, and advancing implementation sciences, so promoting the development, evaluation, and systematic uptake of innovative evidence-based intervention into clinical practice. So really patient-oriented, patient-engaged research based on patient-identified priorities is the foundation of our lab's research, and I think really sets up nicely the context of our study with Indigenous transplant patients and families. I also wanted to introduce our research team, our research circle, as I think it's really important to introduce and locate ourselves, not only as a sign of respect, but also to maintain transparency and authenticity in the research process. So our interdisciplinary team is comprised of patient partners, Indigenous patient partners, researchers, clinicians mainly from 4 pediatric transplant centers across Canada. So CHES here, BC Children's Hospital, Stillwell Children's Hospital in Edmonton, and Health Sciences Center Winnipeg, Children's Hospital in Winnipeg. And I'd also like to take a moment to acknowledge Mary Bocage. So she's the first person on our list here who sadly passed away 2 years ago. And she really was the catalyst of this research. So Mary was Anishinaabe from the Nipissing First Nations, a co-principal investigator on this project, as well as a patient partner, having received a kidney transplant herself. And for those who don't know her, she's also a strong advocate of organ donation, transplantation, and a champion for Indigenous health and leading in Indigenous health research and lens into, I guess, traditional research. So she's a storyteller, teacher, and mentor, and we really miss her on our team. So she left a big hole in our hearts and on the team. And then I also wanted to locate myself as someone who's non-Indigenous doing research in the Indigenous space as a settler. So broadly, I've been kind of in this space involved in Indigenous health research for about 6 years now. My background is in public health, and my master's project was around exploring cultural safety and public health education. And as a health researcher, I think we know about that Indigenous health equity is not where it needs to be and lagging behind. So I'm super honored to be doing this research with my team and working collaboratively in ways that reflect and respect our shared goals. A little background. Indigenous children, including First Nations, Métis, and Inuit, are the fastest growing cohort of children in Canada. But despite this, they continue to face persistent health and social disparities. And when I'm referring to Indigenous peoples here, I'm using this term as an inclusive term to describe individuals and collectives who identify as being related to or having historical continuity with First Peoples of the land. And we deliberately chose this term Indigenous to support assertion for self-definition, while also recognizing the cultural, historical, and political diversity among Indigenous peoples across Canada. So intentionally not taking a pan-Indigenous approach and recognizing the unique experiences and challenges across specific communities. And also when we think about health and social disparities, recognizing that they're multifaceted, complex, with a lot of the upstream factors linked to Canada's ongoing history of colonialism. So land dispossession, discriminatory government policies, anti-Indigenous racism that kind of continue to perpetuate this disempowerment of Indigenous peoples and communities and impacting their healthcare. So within the area of pediatric solid organ transplantation, Indigenous children experience disproportionately higher rate of kidney, liver, cardiovascular, and respiratory diseases. And these conditions can progress to end-stage disease, necessitating transplant at higher rate. So solid organ transplantation is considered the optimal treatment for children with end-stage organ failure. Compared with other life supportive care options, transplant is associated with improved clinical and patient-reported outcomes, including increased life expectancy, quality of life, and decreased patient and health use costs. However, when going through a transplant, it's very complex. So initial referral to a transplant center for pre-transplant education and evaluation. Following transplant, patients must adhere to a very strict regimen of immunosuppressant drug therapy and lifelong medication, lifelong follow-up, clinic visits, tests, procedures, admit health challenges, risk of severe adverse effects, etc. And the barriers for patients and families proceeding through each of these phases are quite multifaceted, especially for Indigenous families who often also encounter structural vulnerabilities, compounded by the lack of culturally safe care in hospital settings. And in 2015, the Truth and Reconciliation Commission of Canada released their summary report following 6 years of information gathering and public discussions with residential school survivors. And one of the key outcomes of the TRC's work was the creation of 94 calls to action. These calls to actions were designed to address the ongoing legacy of residential schools and to chart a path forward for reconciliation, which they define as an ongoing process of establishing and maintaining respectful relationships between Indigenous and non-Indigenous Canadians. And I think of particular relevance of this work is Call to Action 19, which states, in consultation with Aboriginal peoples, to identify and close the gaps in health outcomes between Aboriginal and non-Aboriginal communities, and to publish annual progress reports and assess long-term trends. And such efforts would focus on indicators such as incident child health issues, chronic disease, and the availability of appropriate health resources. And it's been 10 years since the TRC's come out. I think, our work is, this is very relevant to our work in healthcare, and a lot to still work on. So with the TRC calls to action in mind, the overarching objective of this program of research is to advance child health equity by improving access to health outcomes for pediatric solid organ transplantation among Indigenous patients and families. And we have several research questions here. So how can we foster meaningful engagement with Indigenous patients and families as partners in health research? What is known about the need for access to and health outcomes of transplantation among Indigenous children and families? What are the healthcare experiences, stories, and perspectives of Indigenous patients, families, and shareholders? And how can we create synergies with community partners to create culturally safe tools to improve health outcomes in transplant? And I'll be walking you through these research questions, and I'll start with the first one here around how we can foster meaningful engagement with Indigenous patients and families. So I talked a little bit about the inception of this research, working with the late Mary Bocage in developing this research program and centering Indigenous health in transplant research. And I recognize as a team of mainly non-Indigenous researchers and clinicians, there were particular considerations that we had to recognize and engage with to do ethical, meaningful research with Indigenous communities. And I've heard time and time again that research can be quite a very dirty word for Indigenous peoples based on the history of colonialism, but also colonial research of researchers coming into communities, taking their data and then leaving, and that data never really reaching the community or really making an impact. Also stories of researchers misappropriating Indigenous health voices and stories, appropriating their knowledge. And so I think communities have felt a bit hesitant or apprehensive or distrustful around research, which is so fair. And for us, it meant reconsidering the possibilities of what it meant when we say researching with Indigenous peoples in a meaningful way. So not just that the outcomes of research are meaningful, but also that the process of doing research is also meaningful for our partners, our patients, our participants, as well as ourselves. And so that also meant relearning and unlearning a lot of taking for granted assumptions of biomedical Western research. So I highlight here a few considerations and learnings that we engaged with as at the beginning, we started this research journey, and acknowledging that this is a lifelong, continuous process. So first, recognition of Indigenous peoples and of colonial realities. So that they've lived on these lands for millennia, that they have diverse cultures, languages, knowledge systems, important for their health and well-being, and that we can't really talk about equity or disparity without also talking about the impacts of colonialism that continue to manifest to this day. And so I think acknowledging these realities really challenges us to approach this work with more humility. Second is knowing that there are research ethics and protocols specific to Indigenous health research. So some of us might be familiar with the Tri-Council Policy Statement, Chapter 9, Research Involving First Nations, Inuit, Métis people, which outlines kind of key concepts for engaging with Indigenous participants. But there are also specific protocols and I guess, frameworks that each individual community might have. So keeping that in mind as well, to respect cultural practices and in research. Next is that research must support Indigenous self-determination and governance. So that Indigenous people have the right to lead research that concerns their health and priority of the solutions. And so this means for us shared decision-making at every step, informing the research question, interpreting the results, and then even determining how we share these findings and ownership of research. And then lastly, I wanted to highlight what Curtis and Bernhard described as the 4 R's of engaging with Indigenous peoples in research. So respecting Indigenous knowledge systems, traditions, and perspectives as equal to Western paradigm. So listening and treating Indigenous people as co-researchers, not just as participants. Relevant, so making sure that this research is addressing a priority identified by Indigenous people. So this might be tackling health challenges in ways that align with their cultural frameworks and practices. Reciprocity highlights the importance of mutual benefits. So making sure that research needs to benefit Indigenous people, whether through capacity building, tangible resources, actual outcomes, etc. And then responsibility. So for us as researchers to act ethically, uphold commitments, and remain accountable to our research as we conduct it. And there is also a 5th R that we hold to our hearts that is incredibly important and really central to this research, which is relationship building as well and relations with our partners. And we really spent the first few years of this research, and it's continuing. It's a continuous process of trying to build a strong foundation of relationships with Indigenous partners within the transplant space. So reaching out, building relationships for this shared goal of research. And, it's not always an easy process. I think it takes a lot of time, a lot of commitment, a lot of resources, and also a general humbleness that it's kind of different from how we traditionally do research, at least in the Western space. So we established an advisory committee comprised of First Nations and Métis patients and families with lived experience of transplant. And so from the inception, we've been involving them, engaging them, supporting them, collaborating with them to co-lead this research so that the findings can be as relevant as possible to them. And so one of the things that we've been going about in this relationship building is following this pathway called the Wabishki-Bijikoshkanch learning pathway. This was also recommended to us by one of our patient partners as not kind of a check mark of things to do, but as a guide to follow and as activities that we should be taking and working together with our patient partners to build these relationships. So this pathway, I've included a QR code there, is a learning pathway of self-reflection dialogue, and it aims to build cultural safety and ethical ways of researching with Indigenous population. It was co-developed by members of Indigenous-led Council of the CANCEL CKD. This is the National Kidney Disease Organization. And the title of it, Wabishki-Bijikoshkanch, means white horse in Anishinaabe. So we've been following it with our patient partners and our team. And here we have some images. We started, I don't know if people know about the Kairos blanket exercise, but this research started during COVID, so we did some of it virtually. So Kairos blanket exercise, Science cultural competency training, OCAP training, other activities on the learning pathway. And yeah, I think the one thing I do want to emphasize, at least reflections from our experience, is the time commitment for relationship building, the patients, the resources, and even thinking back about the earlier stages of this research, when we were applying for grants and we reached out to our partners, can you send a CV? Can you send a 5-page bio sketch by Tuesday because we need it for this? It kind of felt out of order, asking for aspects of their academic or employment history without also asking about themselves and their days, their lives, their families, their realities. And so sometimes I think is acknowledging that our meetings will be half, asking about each other, and then the other half might be the research aspect of it, and perhaps not meeting all the agenda goals of the meeting, but still coming out of it, learning something and having a stronger relationship. And I think that's what's been the most meaningful of this process. Okay, so going back to research objective, advancing child health equity by improving access to health outcomes of pediatric transplantation among Indigenous patients and families. And so we'll go to our second research question here. What is known about the need for access to and health outcomes of transplantation among Indigenous children and families? And so we're taking a three-phased mixed methods research design where each phase builds upon the previous phase. So this includes phase one, a scoping review to characterize the international landscape and identify knowledge gaps relating to access, survival, and health outcomes of transplant among Indigenous children. This was completed in 2023. Phase two, qualitative interviews with Indigenous patients, families, and shareholders to elicit their stories and experiences of transplant and identify system-level barriers and facilitators to improve care. This phase is ongoing. And then phase three is a reciprocal knowledge sharing workshop or event or tangible thing that we're still figuring out to share our research and maximize impact and outcomes. And I think, as mentioned, we are partnering with 4 sites total, so CHES, BC Children's Hospital, Solar Children's Hospital, and Health Sciences Center. And so with the first phase, we did a scoping review to characterize international literature and look at knowledge gaps relating to access, survival, and health outcomes for Indigenous pediatric patients in settler colonial states. So Canada, United States, Australia, and Interior New Zealand. And we focus on these countries because we found a significant gap in the Canadian literature specific to pediatrics. There wasn't enough articles out there to do a scoping review. And so we decided to expand our scope internationally to allow us to kind of draw insights and comparisons from other countries with shared colonial histories. So First Nations and Inuit and Métis peoples of Canada, Maori peoples of Interior New Zealand, Aboriginal and Torres Strait Islander peoples of Australia, and Native American and Alaska Native people of the United States. And so I think while we did take an international approach, I think it's also important to acknowledge the distinct identities and traditions and knowledge systems that are foundational within these populations, but also acknowledging that the shared histories of colonization, marginalization, intergenerational trauma, as well as resilience of these populations. So we summarize the current body of knowledge within transplant to identify evidence gaps and inform research priorities. Our participants were Indigenous children. Concept was characteristics of access to care and health outcomes. And the context was Canada, Interior New Zealand, Australia, and the US. And we did this process with our patient advisory committee. So they helped with search terms, what were some appropriate terms that we could use, co-developing the search strategy, sharing feedback on the results and interpretation of the data, reviewing, editing the final manuscript, and being named authors on the publication that are published. So this is the scoping review process. I won't bore you with this, but we had 7 articles from the US, 6 from Canada, 5 from New Zealand, 5 from Australia, and 1 from both Australia and New Zealand. In terms of the organ groups, we looked at majority kidney, so 13 articles focused on kidney, 10 focused on liver, and we had 1 article that focused on heart, so mainly kidney and liver. And if we turn to the results now, so we categorized our findings based on organ groups, kidney, liver, and heart. And when we looked at the kidney articles, our findings identified disparities for Indigenous pediatric patients with kidney failure. So children experience longer duration on dialysis, which is the process before transplant, lower rates of preemptive kidney transplantation. So this is the preferred modality of kidney replacement therapy. And Indigenous children are also less likely to receive a living donor kidney transplant. So for example, one Canadian study reported that First Nations patients were less likely to receive a kidney transplant from any source, from a living donor or from a deceased donor compared to white patients. And several studies also documented differences in long-term kidney graft outcomes and patient survival, showing poor outcomes for Indigenous children compared to non-Indigenous children following transplant. Turning to liver transplant, the results are quite mixed here. So among pediatric patients with liver failure, some studies found Indigenous children were kind of overrepresented in the transplant population. Others found that they were underrepresented. And when it came to graft outcomes and patient survival, studies reported pretty comparable outcomes among Indigenous, non-Indigenous children. So for example, one study showed that all children who had received a liver transplant, including Maori children in New Zealand, were reported to be living at home, attending school, kind of reflecting favorable post-transplant outcomes. And then in the one heart transplant article, there was not really a lot of data in terms of outcomes or access to transplant in this population. And our scoping review also explored the social determinants of health that may impact access and outcomes to solid organ transplantation. So we kind of group these into three categories: geography of relocation, lack of cultural safety, and lack of well-matched organ donors. So in terms of geography relocation, our findings identified that a greater proportion of Indigenous children lived further from pediatric transplant centers or in very remote locations. So one study found that, remoteness of residence was a sole predictor of death and retransplantation among pediatric liver transplant recipients, with increased rates among First Nations patients. Lack of specialized care, medical support in remote communities is a known barrier to accessing healthcare for Indigenous people in health, and patients often need to relocate to an urban center. Lack of cultural safety, so limited integration of traditional knowledge, healing practices, ways of being into Western systems, another determinant. So one study really highlighted that traditional spiritual beliefs about transplant influence the acceptance of transplant as life-saving therapy. So underscoring the need for cultural safe and inclusive care models for patients and families. And then shortage of suitable donors. So lack of donors was also a determinant. Many studies found that a lack of donor was a critical issue for First Nations patients, resulting in fewer transplants. Additionally, disparities in graft outcomes for kidney transplant participants were linked to limited availability of living donors and well-matched deceased donors. And then in the adult literature, we've seen that patients have really reported that pursuing living transplant is complicated by reluctance to accept an organ from a family or a community member, and the need to integrate kind of cultural practices into the transplant experience to honor the donor. So, for example, like smudging or healing circles to honor them. And I think these are all areas that we know for further research with Indigenous patients. So I'll review some of the evidence gaps in the scope of review. Really the lack of discussion contextualizing impact of colonization. So really no mentioning of that in any of the articles we reviewed, which can be critical barriers to shaping access and outcomes. Also, substantial gaps in evidence related to heart, lung, pancreas, and multi-organ transplantation for Indigenous pediatric patients. A lack of focus on patient-reported outcomes. Many of these were essentially health statistics they looked at, never really asking them about their outcomes. A lack of strength-based perspectives. So nothing really that emphasized resilience or well-being. And then in terms of research methodologies, there was a lack of community-based and participatory research approaches in the articles that we found. And I think only one of the articles explicitly reported working with Indigenous partners in their paper. And I think, participatory approaches, especially with Indigenous shareholders, community leaders, patient voices are necessary for this research concerning Indigenous peoples. So in terms of future research within local community-led contexts, interconnectedness of the social determinants of health, colonization, and transplant outcomes, and also the need for community-driven approaches for culturally safe healthcare delivery. And so from that, we can go now to our third research question: what are the healthcare experiences, stories, and perspectives of Indigenous patients and families, and really trying to address some of the gaps that we found in our scope of review. And so this is here the second phase, are interviews and stories with patients and families. And again, as mentioned, this phase is still ongoing, so we'll be highlighting mainly our methodology and sharing some preliminary findings as a teaser for more to come. So this phase is a multi-site qualitative study aiming to capture the stories and voices of Indigenous patients and families, as well as other healthcare actors around their transplant experiences and looking at barriers and opportunities to enhance care and outcomes for this population. And we mainly recruited across our 4 sites, so SickKids, BC Children's Hospital, Soldier Children's Hospital, and Winnipeg. And we invited participants essentially to share their transplant story with us kind of via in-depth interviews, one-on-one interviews, in ways that they felt most comfortable with. And so this phase was also really co-developed with our patient partners, especially with the late Mary Bocage, as well as the other members, who really emphasized the importance of storytelling as a knowledge-sharing tradition in many Indigenous cultures. So one of the first things that Mary said as we were, conceptualizing this phase was Indigenous stories are a strength, and storytelling as a strength-based approach for understanding health experiences, building relationships, and as knowledge and data. And so from our scoping review, we saw gaps that existing research was mainly quantitative, retrospective, kind of health database stats that often compared Indigenous patients with white patients or non-Indigenous patients. And that findings were often reported as disparities without acknowledging, colonization or the strength of communities. And so with this phase, we really are trying to address some of these evidence gaps by centering Indigenous voices and their stories on their terms. And I think the power of storytelling can be multiple. So stories can transmit and sustain knowledge, reinforce Indigenous knowledge systems, and oftentimes can contain a lesson or a teaching to the recipient of the story. So we completed 25 interviews with 30 participants. We had 8 pediatric patients between the ages of 10 and 17, 18 family caregivers, so parents, grandparents, adoptive parents, foster parents, and 4 healthcare actors. So these were healthcare providers, health navigators, etc. And the interviews were semi-structured and open-ended and really guided by the participant in terms of what they felt was important to share about their experiences. So there was a pre-developed interview guide, but in most cases, we really let the participant really guide and take us where they want to go. And in terms of qualitative story analysis, data analysis, we've been following Joanne Archibald's story work principles of respect, responsibility, reverence, reciprocity, holism, interrelatedness, and synergy, which I'll talk about next. And then also in this process of collaborating with our patient partners around findings and interpretation. So having pretty consistent meetings with them in terms of what are we interpreting and are we doing the best that we can do in terms of interpreting it in the most meaningful way. So Archibald's work principles, Joanne Archibald is a scholar from the West Coast, from DC, and she has these 7 sort of principles as a way of making meaning from interviews with Indigenous folks. The first 4 principles surround the ethics of engaging with Indigenous stories. So it's very similar to the 4 R's of research mentioned earlier. So respect for the people who owned and shared the stories, responsibility, so carrying out this research in a responsible manner, and the responsibility of their stories in their accuracy and authenticity, reverence, so cultural knowledge embedded in stories, the ceremony, reciprocity, giving research back to communities and sharing the learnings with others. And then the latter 3 is more around how to interpret or make meaning from the story. So holism, looking at the intellectual, spiritual, emotional, physical dimensions of stories, interrelatedness, so the interrelatedness between the story, the storyteller, and the listener, and how this all kind of like leads the story. And then synergy is the power captured or created during storytelling with kind of like healing aspects. And I think part of this is also acknowledging that these stories that we were listening to, don't necessarily have like a beginning, middle, and end, kind of like how we think about traditional stories. They're living stories, they're continually developing, and also sometimes circular or weave in and out, and sometimes also contain a lesson or a message, a key message or lesson. I think that also highlights, the importance of our patient partners and the insider outsider dichotomy that we have as researchers, and our patient partners with their lived experiences. And so having their lived experience and kind of cultural lens in supporting the interpretation of our results, with us kind of bringing the more methodological aspect of it, and them bringing more of the meaning making aspect of our findings. Okay, so broadly, we're going to be presenting these 7 story threads that have been emerging across participant stories. And these first ones are mainly from patients and caregivers, mainly caregivers. And each thread here represents a spectrum of experiences, and individual stories may kind of weave across these spectrums and layers, reflecting the complexity of their transplant story. So first we have identity and community. And I think the key piece of this is that Indigenous people hold unique and diverse relations with their culture. And this thread really forms the foundation of many of the stories. Participants, started each story talking about who they are and what their relationship with their identity is. And that this relationship actually was quite wide ranging, from really strong cultural ties to their identity, to being urban Indigenous and moving a lot, to being maybe quite separated from their cultural ties, to being adopted or displaced from their community. And so for many, there's also really powerful narratives of reclaiming and re-owning their identity throughout their story. And among those who lived on reserves or rural or remote communities, there was also a great deal of detail in terms of outlining the connection they had with their community and their land in ways that was just more physical place to live on, but also in a way like metaphysical. So that really set the foundation of a lot of the stories. The second thread is accessing healthcare can be challenging. So in discussing their experiences with the healthcare system, even before the topic of transplant comes up, or the challenges of accessing kind of basic healthcare for many Indigenous people. So this is particularly salient among those living in rural remote communities, where they had maybe a local clinic, or they had a clinician coming into the community a few times a week, but not having kind of a hospital there. So some participants noted that clinicians were often not trained on specialized care, or lack of kind of equipment, so having to travel out to seek care. There's also kind of a general perception among our participants of discrimination within the healthcare system. So assumptions, perceptions, negative stereotypes that generally led to kind of a distrust with the healthcare system. And I think collectively this ultimately manifested in several patients and family members, especially younger parents, talking about receiving inadequate care or delayed care. And one parent even, she spoke about her care as being she was failed medically. So the third thread is the importance of relational care. So patients and families often travel to larger urban centers for diagnosis, treatment, follow-up, and many participants described a sense of culture shock when coming to a big institution like CHES. So being away from their family, being away from their community, their culture, and feeling very much unfamiliar with being in a healthcare space. And this was sometimes contrasted to the holistic perception of health that they had emphasized or were familiar with. Some participants talked about difficulties in communication, especially with the fast pace of decision making and communication, and sometimes filled with medical jargon, and having difficulty in understanding or navigating the healthcare system. There was also kind of a common description of Indigenous invisibility, so not seeing other healthcare providers who looked like them, not knowing what was available, what sort of resources were available, if there were even Indigenous specific approaches available in care, and also sometimes not wanting to speak out because of not wanting to feel like they didn't know or etc. And those who are urban or kind of lived within the city also talked about not having a community to fall back on. That was the importance of relational care for them was really emphasized. The fourth thread is the decision for and experience of transplant. So this period between, diagnosis and transplant was often described for many as a very, very intense period, very fast paced. And many patients and families actually didn't really talk much about, this experience. It was, we got diagnosed and then we got the transplant. It was everything afterwards and nothing really about the process of transplant. So we had to really kind of ask a lot more follow-up questions about this particular part of their story. And there was also kind of this perception, I guess, among many participants that life transplant for them was life saving, that it had saved your child because most of the participants we interviewed were post-transplant. There are also a few participants who talked about kind of hesitations around pondering the spiritual implications of transplant, kind of questioning, how to move forward in terms of does it go against their spiritual backgrounds. Others saw it kind of as the only way forward to preserve life, or that, if transplant was available, then Creator had meant it for be there. So kind of different perspectives in terms of decision making to accept transplant. Donation was also a very complex topic, complex discussion. And for a lot of our patients, family and friends did volunteer to donate, but the donation criteria made it difficult for some family members to donate because of the criteria for example, like your BMI has to be a certain range, you couldn't have comorbidities, etc. So this is a very complex, but also often skipped over portion of their stories. The fifth thread is transplant structural barriers. So, patients and participants and caregivers talk a lot about the myriad of structural barriers for them to get the transplant. So geography and moving and the disruption to their lives. Also the disruption to education and work, especially for younger parents who had to put education and work on hold. There was also a myriad of financial considerations in terms of how do they fund this, and now that they're moving here, where are they staying, all those sorts of considerations. A lot of participants talked about support from Jordan's principle or non-insured health benefits, and then also some administrative or kind of structural barriers in terms of knowing what's available and how to access it, and all the paperwork and all the administrative lagging and all those sorts of challenges as well. And then lastly, there was also this sense of Indigenous invisibility. So not knowing what was available for them, and then maybe learning after the fact that this was available for them to support them in their journey. The sixth thread is around advocacy and resilience. And I think across all the stories, participants really talked about that they really had to advocate for themselves or for their child. And that resilience was really a core aspect of their stories. So participants shared accounts of having to learn really quick about the healthcare system, navigating it and kind of having to learn quick, advocate fiercely for their child in the face of unequal care. So countless stories of, kind of pushing back on clinicians. There's also many stories of healthcare champions. So having one healthcare provider, a social worker, a health navigator there that supported them in their journey, not just medically, but also emotionally and socially, as well as talking about support from their broader communities, from their friends, from their family. And the support kind of ranged in different aspects, not just physical support, but financial, emotional, spiritual support as well. And then the last that we have is desire for safe and inclusive care. And I think this captures this widespread desire for care that fosters safety and belonging among a lot of our patients and families. So many families express a need for spaces within hospitals where Indigenous patients and families could ground themselves. Suggestions also included increased training and education for healthcare providers around cultural safety, greater Indigenous representation in healthcare in the hospital, including having elders or knowledge keepers present, as well as the option to integrate both traditional and Western medicine into their care. So we only interviewed 4 healthcare actors, but I think The key message from our healthcare actors points to the need to heal fragmented relationships between Indigenous communities and healthcare systems. So I wanted to kind of lead with this quote here. So we need to start somehow dismantling the fragmented relationship with the healthcare setting. Relational engagement is going to be important. There needs to be some sort of reconciliatory process to bridge that gap. And as I said, this data is still ongoing, so we are still kind of analyzing it. And with that, we'll go back now to our last question here. So how can we create synergies with community partners to create culturally safe tools to improve health outcomes for pediatric solid organ transplantation? Right there. And so this is kind of our next phase, knowledge sharing, this year and next year. And originally we had envisioned this as a knowledge sharing event or workshop that we could bring different partners together or participants, patients, families, healthcare providers together and share through like a workshop or an event in a meaningful way. But as we talked to our participants and our partners, we realized that maybe this workshop isn't the best approach and that there are other ways that we could also share. And I think our participants really highlighted something tangible for them also to take away after they had given something to us, their stories. So we are exploring other arts-based approaches in terms of sharing these findings, digital storytelling video perhaps of, you know, having participants share their story and capturing that in visual format. And that also might be better for our patients and families too, in terms of rather than like a manuscript. We're also thinking of perhaps collaborative beadwork or some sort of artwork that we could create to represent their stories and have it as a piece that could be at some of these healthcare institutions. But I think our real goal here now is, you know, how do we share this in a way that reflects our partners and participants? What are some other future priorities for research? And also how can we build capacity as we go through this process? So this is my last slide. And really with a better understanding of the lives, cultures, and stories and experiences of Indigenous patients and families, we believe that healthcare institutions can move towards improving access and care for this population. We hope that our findings will directly address the TRC calls to action and that we are essentially continuing this research and our community building and our relational process even beyond this research. We hope to continue our relationship. Thank you so much. Really want to thank our partners, our participants for sharing their stories. This research would be possible without them. Our funders, the Leong Center, and our collaborators, our research team. So thank you so much for joining.
Thank you. I want to open up the floor to any questions from the group. Hi.
First of all, let me say I commend you on this work. This is really incredible, and I think this is, especially the structure of this study, it's co-design par excellence. So thank you. I really do appreciate what's happening here at CHES and that you're leading the study. I am so curious because I know that relationship building piece is so important, especially for a study like this, where you're asking people to share their vulnerable stories. And I'm so curious, I know this is a barrier in other institutions also to doing this work. What was the funding journey like for this? Like, what did you experience barriers, right? Like you can't even promise results maybe in the first year. You don't even know what that's going to look like. So I guess one part of the question is, what was that like? If you could share some of that. And the second part is, with that training, with all the preparation you did for your team, even after that, once you start doing the work, are there any cultural safety skill barriers that kept coming up, maybe especially with respect to the CHES team, that you noted as opportunities for a future skill development, even beyond that sort of online training and certification?
Mm-hmm. I think your first question is so important because with relationship building, but then we have kind of these funding applications. We don't have the money yet. And for us, it was kind of, we were lucky to have a small seed grant for the Leong that kind of supported us. And then we, with that, we were able to, bring our partners together, say, hey, like this is kind of going a good direction. Do you want to continue this process? and work together. We have 3 funders on our list here, so we applied to multiple grants, and we kind of, started first with the scope review. Let's start small, and then we moved on to the interviews too. I think, Mary was a really key person in developing those relationships. She was Indigenous, so she had the credibility that I think a lot of members of our team were kind of hesitant to reach out to certain individuals or organizations or partners to say, hey, we don't want to just like come in to say, hey, do you want to partner on this research project that we are thinking of? And I think having Mary there from the beginning, saying, let's do it this way instead of this way, and let's not jump to conclusions to say this is what phase 3 looks like. We can give a kind of an idea and work with our partners around that. I think our clinicians too really helped with connecting us to families that wanted to be part of research, not only for the outcome, but I think a lot of our partners have said, thank you for including our voices in this process and learning about research too. And I didn't know that I could be part of this process too. And I think that commitment from them too has really helped us move forward. And like, once we have that commitment, able to apply for multiple grants along the journey. In terms of your second question around, what are some of the key learnings and kind of issues that come up? This is like, we have been following the local distribution funds learning journey pathway. And, we started at the beginning and we're kind of going through the different activities. And of course, with, our team is across Canada. We have people from BC, we have people from the different provinces. So sometimes the virtual is the only way that we're able to do these practices together or like do these activities together. And I think it's, like having our patient partners there and seeing them on the screen kind of reminds us that we have a shared goal together. And that, it's kind of a reminder each time we come together and we see their faces that like, okay, this project is still going. We still have these commitments to uphold, and we all have this shared goal that we're working towards.
So having that champion on the project team and it's just part of working with the community. Really, it's awesome.
Jump in.
Yeah.
Before we started this, I consulted with several other scholars, and they had said, if you're going to do this work, you need the time. And I have to say, commitment, the dedication, and the time. Every single interview was probably a year of relationship building with all the participants. Who are you? What is the research? What are the goals? So they felt safe and they trusted us in order to share their story. So very different. We do a lot of qualitative research within our lab. And I think one of the things too, when you apply to grants, you're like, you have 3 years, what are your deliverables at the end? I think there has been a shift in understanding that this research takes time and that these relationships that you're building are lifelong.
Yeah.
So I think one of the things we really struggled with is that our research within pediatric solid organ transplantation is national in scope. And I think what would have been helpful knowing going in is that how do you build relationships across so many different communities in Canada? And that was a significant hurdle for us. So I think if we were doing it again, it might be, you would get the same numbers, but I think starting with specific communities and going there. I think that's a really important thing, is actually physically being present, being part of different rituals and ceremonies within communities. And I think having, dedicated patient partners who have given so much time and energy to this project that we are immensely grateful for. So we have, thank you, Leong Center, because we've been needing to ask for extensions. Even CIHR, I think you get the mandatory 1 year for the pandemic, but we will be going back to them. Even how we've had to shift focus. So we thought we'd be doing this workshop, and now it's probably looking much more arts-based and having that driven by the patients and the families, but what is most meaningful for your community and what would that look like? So I think very, very mindful of kind of, we need to get presentations and manuscripts out.
The deadlines are different.
Yes.
Yeah,
Deadlines.
the deadlines are different and they also look different.
I think being patient, which is something I don't have a lot of, so it's been really interesting trying to schedule meetings and it taking a year to meet, and then being mindful of that. So it's definitely been an interesting journey.
Thank
you. Yes. Hi.
excellent work, especially hearing about the long process of relationship building with participants. As a student also doing mixed methods work, the thing that's on my mind a lot these days is how do we get these findings out there to the right people? So for example, if you're hearing that Indigenous patients want more time to make healthcare decisions and consult their communities, how do you have a plan yet to get that information kind of out to the right people to say, hey, this is something that's important and it's the change we need to make as healthcare providers?
Yeah, I think this brings me back to a recent meeting we had at CBS. And they asked us, Canadian Blood Services, and they've been a huge supporter in this work. And they asked us, like, who are your target audiences and how do you want to communicate, these research findings to your target audiences? And so, in that meeting, we talked about different organizations that we could share these findings with. So we talked about, the digital stories that we might be more, that patients and families might enjoy more, but also looking at different organizations or partners, even institutions, healthcare clinicians around how do we then share some of this tailored towards them. And so I think, rounds is a good option for clinicians, clinical rounds, but also perhaps reports for organizations, Indigenous health children's organizations too, around some of these things that are coming out of our findings. And also following up, because I think a lot of times we share our findings and we never track what happens to them. And I think we really, KT is our third phase. It's not just first two phases, then we just leave our research. So I think over this year, next year, year after, continuously, we're going to be following up to see, what's happening once we've shared, and what can we do better.
Tony, are there any questions online? Yes.
Great presentation. This is really amazing work. And my question kind of builds off the last. I think you mentioned that in the interview, something that came up was this idea that there are resources, but they weren't informed of them in a timely enough way to make use of. So I kind of wanted to get your perspective of based on the research that you guys have done, do you find that there are adequate resources and they're just not being communicated well enough? Or do you think there is still a gap in the types of resources that patients and families need?
I think, so I know CHES has an Indigenous Health Navigator now, but they recently recruited a few years ago. And I think a lot of other institutions now have health navigators, or maybe they'll have a cultural space, or they'll have opportunities now to integrate more traditional practices into the care. But I think for most of the participants, their kids having received a transplant 8 to 10 years ago, that was probably not the case for them. A lot of the support they also talked about was financial support related to Jordan's principle, which supports First Nations kids in receiving care, or non-insured health benefits, and not kind of being informed that those are options for them until maybe a few months later. And a lot of the stories were like, oh, well, I wish I had known that, because then I would have done this differently, or I would have been less stressed out, or I would have been X, Y, Z. And so that invisibility, I think, maybe still is a thing here of maybe we have a health navigator, but do all patients and families know that there is a health navigator, and that this is the role that the health navigator can support you on? Even with social workers, I feel like a lot of our patients' families said, I kind of had a bad connotation of what social workers mean, because in our history, it's they take your kids away. But a social worker at the hospital maybe can help you find lodging, or help you with accommodations, or if you're flying in back and forth, they can help you with some of the financial considerations around that. So even closing that barrier around, okay, this is what a social worker can help you on. These are the roles of the health navigator. This is how you can contact them if you need them. Things like that, I think, could be better communicated. Yeah.
Your question, even being one of the co-PIs as a social worker, I was very mindful of my identity and meeting with families. I don't think, after 25 years of clinical experience, I don't think I've ever met a family who hasn't been impacted financially when they have a child with complex medical needs. I think there will always be a gap, and even more so for different communities. So thank you for your question. And Thank you so much. This was fantastic. Don't forget rounds next week. There'll be further communication this week, so stay tuned. And I hope everyone enjoys the rest of their Monday. Thanks for coming.